We have Dr. Alexandria Ratzki-Leewing, who is an adjunct professor and research scientist in the Department of Epidemiology and Biostatistics and Family Medicine at the Schulich School of Medicine and Dentistry of Western University, which is in Ontario, Canada. She is also co-founder and director of the university's hypoglycemia research program at the Center for Studies of Family Medicine. Dr. Ratzki-Leewing received her PhD in epidemiology and biostatistics from the Schulich School of Medicine and Dentistry at Western University in 2022. And before that, her Master of Science in Health Research Methodology with a specialization in health services research from McMaster's University. With over 15 years of research experience, she's conceived, designed, and conducted primary studies in over 12 countries, spanning 4 continents. Currently, she serves as principal investigator for the IN-HYPO-DM study in Canada and the IN-PHORM study in the United States, which is America's largest prospective investigation on hypoglycemia risk. As a global expert in real-world diabetes epidemiology and survey design, Dr. Ratzki-Leewing has consulted for multiple policy and clinical advisory boards, such as Statistics Canada, Diabetes Canada, and the American Diabetes Association. In 2023, she was invited to join the steering committee of the International Hypoglycemia Study Group, and is very much sought after as an opinion leader, both in the United States and in Canada. Her work features major diabetes clinical practice, is featured in major clinical practice guidelines, and is at key forums in North America, Europe, and Asia. In the last five years, she's delivered 15 national and international presentations with more than 10 invited symposia at congresses. She's especially known for her ability to educate diverse student, professional, and community audiences on topics related to primary care and diabetes epidemiology. And in 2023, the International Diabetes Center in the United States named her as a rising star for her outstanding contributions to diabetes research and practice.
And thank you everybody so much for your patience. It's a sincere pleasure to be here today. Thank you for the very warm introduction. I'm Dr. Alexandria Ratzki-Leewing. I've been based at Western University in Ontario, Canada for about the last probably 10 years. And that's been doing some work in hypoglycemia and also completing my doctorate degree in epidemiology and biostats related to hypoglycemia. So it's a pleasure that I'm going to be able to present to you guys today on real world data, and specifically, a question that's arisen a lot in our research, which is how real are real world data? And I'm going to use hypoglycemia as the case example. And I'm also, for many of you in this group, going to focus specifically on those who are in the older adult population. But first, some obligatory disclosures. So I do have some industry affiliations. I've received grant money from Sanofi Global. I've also been on advisory boards for them, and I've done some presentations for them, as well as Sanofi Canada. I've consulted for Abbott, which is a diabetes device company, Eli Lilly, and Dexcom, as well as Novo Nordisk Global. I've also done work for some nonprofit organizations, including the American Diabetes Association, Diabetes Canada, and also the International Hypoglycemia Study Group. My disclosures don't just end there. I am Canadian, born and trained. I got my undergrad at Western University, actually, and I did a writing diploma simultaneously. I did my master's degree at McMaster University, as Dr. Mike Zeno mentioned, in health research methodology with a subspecialization in health services research. And then I came back to Western to do my doctorate training with Dr. Stuart Harris, who I'll talk about briefly in a minute. So my time at Western University and McMaster really led to some incredible collaborations, and that is going to be featured a lot throughout this presentation in the work of InHypo, which was a nationwide Canada study, and then also INFORM, which was a longitudinal investigation conducted across the United States. And of course, mentorship. I don't think an academic can rightly talk about their career in academia without mentioning the amazing mentors who've allowed them to get to where they are and facilitated that. So this is a very thoughtful Dr. Stuart Harris in this picture. And he's been the mentor throughout my doctorate training, as well as, I would say, very strongly my professional mentor, facilitating collaborations with the ADA, although he's Canadian. He's done a lot of work internationally in diabetes and in primary care specifically. And then my incredible doctorate thesis advisors, ranging from biostatisticians, psychometrists, methodologists. The man in the mask is the first person in Canada to do a liver transplant, and also Brian Freer, who's a major hypoglycemia research maven. And then my pet, my dog, Indy, life mentor, teaching me to drink a lot of water when you're thirsty and to go out for regular walks. Okay, so diving into today's presentation and the topic of the advertisement, which is to discuss the current insights into hypoglycemia as a result of insulin and or secretagogues use. And we're gonna, as I mentioned, focus in an aging diabetes population. We're going to also start to interrogate some of the methodologic pitfalls that we've been identifying in our research and that's been identified globally that can perhaps lead to a metaphor of quicksand results. And then I'm going to forecast some future directions in hypoglycemia research and kind of situate myself within that in the immediate term of the types of research that I would like to do and hopefully bring here. So to orient everybody, hypoglycemia as a clinical problem. So these are some data that I took from CDC in a user-generated report. And you can see that from 2000 to 2021, the rates, or the percentage rather, of diabetes in the United States in varying age cohorts from 18 to 44 to over 75 have remained relatively unabated, with a somewhat increasing rate for those who are between 65 and 74 and over 75. And what we also know is that from these data, about 25% of individuals over 65 are getting diagnosed with diabetes in the United States. Within this population, and these are Canadian data, but I think they can be extrapolated to the American context, we see a high use of insulin and secretagogue therapy regimens in the older adult population, and specifically sulfonylureas and insulin, and you can compare that to meglitinides, for example, where in the type 2 population, we're seeing about a 68% of people who are on hypoglycemia-inducing agents, that being insulin and secretagogues. Within this population, we might ask, okay, how many people with type 2 are actually taking insulin versus secretagogues versus the combination of the two? Therapeutically, we might think that the combination maybe doesn't make a lot of sense, but yet in real world context, we see that it's prescribed quite often together. And these are data from the INFORM study, and we found that about 10% of individuals were on a combination therapy of insulin and secretagogues. And this becomes very clinically relevant because the combination of medications has been associated with increased rates of severe hypoglycemia and also cardiovascular outcomes and mortality. So just briefly to kind of give you guys a physiologic schematic of hypoglycemia. So in a person without diabetes with decreasing blood glucose concentrations, generally what happens is you'll see a reduction of the insulin secretion pathways, and you also see an increase in glucagon secretion. And then as blood glucose levels continue to drop, you see an adrenergic response of epinephrine increase, and then symptoms will begin to show. And these symptoms then are going to be counteracted by a glucose correction within the body. However, for a person with diabetes, what ends up happening is that in people with type 1 and those with advanced type 2 diabetes, the insulin secretion reduction and the increase in glucagon secretion to try to drive those blood sugar levels up starts to severely depreciate, if not completely go absent. And then also you have this defective counter-regulatory response that can lead to a loss of warning symptoms and eventually a clinical syndrome known as impaired awareness of hypoglycemia, that can both physiologically and behaviorally impact a person's ability to act on incipient lows. And then what ends up happening is you end up creating this vicious cycle of recurrent hypoglycemia. And this physiologic response in a person who's older or in an aging population is even exacerbated. And so among the aging population, irrespective of previous exposures to hypoglycemia, there's a slower rise or an attenuation of the blood glucose recovery process. There's also a decrease in the magnitude of those counter-regulatory hormonal responses. And this can lead to a reduction or a decrease in the intensity of symptoms that are experienced, and also differences in the types of symptoms that are experienced by these individuals. And then ultimately the glycemic threshold for symptoms onsets can be altered, resulting in conditions like impaired awareness of hypoglycemia. So as of about 2017, the International Hypoglycemia Study Group collaborated with the American Diabetes Association, as well as the European Association for the Study of Diabetes, to kind of create this nomenclature, taxonomy of severity of hypoglycemia. So what they created were these 3 levels, and the first one is essentially a non-severe event defined as any event that is characterized by a blood glucose level of less than or equal to 70 milligrams per deciliter. And this is generally regarded as a glucose alert value. Your blood glucose levels are going low. They also introduced an idea of the level 2 hypoglycemia. And these are events that have a blood glucose threshold of less than 54 milligrams per deciliter. And they introduced this because they found that in the literature, this glucose threshold was associated with various serious and clinically important outcomes. And they looked at, for example, the onset of recurrent hypoglycemia following this type of level 2 event, also the increased risk of impaired awareness. They found that it was also associated with impaired cognition, cardiac arrhythmias that can predict mortality, and then also other health economic impacts. And then, of course, there was level 3 hypoglycemia, which really was just a renaming of severe hypoglycemia. And for the most part, you will see those words interchanged, although I'm going to be very specific in the terminology that I'm going to use today in this presentation. So how they define level 3 hypoglycemia, and now this guideline recommendation has really been uptaken by the ADA, by Diabetes Canada, across the world, and how they define it as any low blood glucose event, regardless of blood glucose threshold, that requires the individual to receive third-party assistance to treat that event. And that third-party assistance can be in the form of a healthcare provider, in hospital, out of hospital, or it can be from a family member, a friend, a colleague, outside of the healthcare context. And this becomes important for this presentation, as you'll see. So frequent causes, I think not surprisingly, we see that irregular and insufficient carbohydrate intake, and then unintentionally taking the wrong insulin product, so taking bolus instead of taking basal bolus, et cetera. And then also taking the incorrect dose is going to precipitate a hypoglycemia event. And there have also been a ton of risk factors described in the explanatory literature. And here we can see that some of them are treatment related, some of them are anthropometric or clinically related, and then some of them are related to the sociodemographic nature of that individual, as well as other environmental characteristics. And these risk factors can play a role in whether or not hypoglycemia is more or less likely to occur. And when a hypoglycemia event occurs, particularly severe hypoglycemia, that's going to lead to another range of physical and psychosocial morbidity, and even an increased risk of sudden or all-cause mortality. In a very vicious and dangerous bidirectional relationship with frailty in individuals predominantly over the age of 75, as described in the research, we see that hypoglycemia occurrence can increase the impacts of frailty, and that frailty can vice versa have an impact on the occurrence of hypoglycemia. And all of this can kind of clash together in an increased risk for disability, loss of independence, which we know is extremely important to older adult populations, need for increased support as a corollary, and then also other worse clinical outcomes. This all culminates in high associated direct and indirect costs. These are not specifically associated to the older adult population, and we will continue, hopefully, at this university to delve into the economic impacts among older adults who are experiencing hypo. But just broadly speaking, hospitalization resulting from hypoglycemia costs the United States over $1.8 billion a year. But these are just events that result in hospitalization. because. And we're frozen. Okay. Yeah, up there.
Can you right click and see?
There we go. Because, as I was saying, in addition to events that result in hospitalization, as I mentioned, there are a ton of events that are occurring outside of the healthcare context. So, or outside of the hospitalization related context. So we have to think about ED related events that are not resulting in admission. We have to think about non-transport paramedic treated events. And then of course, those hypoglycemia events that are treated at home by a family member friend. How does this impact follow-up consults and education among people with diabetes? And then what is the cost also for prescribing glucose treatments, glucagon treatments, and also just making sure that individuals have blood glucose testing strips on hand. We don't really know what the impact of hypoglycemia is on lost productivity, absenteeism from work, loss of earnings, although more recent modeling has been able to start uncovering this in the United States. But how that actually translates to broader cost-related morbidity is still unknown, and we really need to start working in that space. Hypoglycemia is a population problem. We've now calibrated our understandings of hypoglycemia as a clinical problem. Let's jump in to the population-based problem. Descriptive frequency data became really important to me as I entered into the hypoglycemia space because I realized there really weren't those types of data existing in this context. And we know that it's important epidemiologically because it can inform population health strategies for monitoring, informing public policies, evaluating health interventions, understanding disease burden, identifying high-risk groups, allocating population health resources. And clinically, it's important too, because we also want to think about monitoring treatment outcomes. We want to think about decision-making, particularly around these medications that induce hypoglycemia. We also want to think about patient education and allocating healthcare resources. But without this base of strong and valid descriptive epidemiologic data, how can we actually inform these types of strategies moving forward? If you take a look at the landscape of hypoglycemic data that relates to just trying to capture its incidence in populations, you're going to find a lot of very disparate research. Some of the evidence is going to be cited from trials. Some of it is going to be cited from healthcare records. Some of it's going to be from patient self-report or person self-reported data. Some of it's going to come from glucometers. And you'll see more and more of that now as continuous glucose monitoring becomes more accessible among people with diabetes. And then all of this is kind of just cloaked in a further heterogeneity of what population did they include in that study? Where was the study conducted? And when was it conducted, particularly as we look at older adult populations? So let's start where I think lots of people like to start, with trials. Trials really were incredibly important to the story of hypoglycemia. And we know that they have high internal validity. If they're well conducted, they are generally characterized by highly controlled conditions, rigorously defined and enforced protocols with frequent monitoring. And these trials that were conducted in diabetes, these landmark trials, showed, very importantly, that intensive glycemic control increased the risk for hypoglycemia. So the harder you drive those blood glucose down to a euglycemic level, you're going to see an increase in the risk of hypoglycemia. And this really did start to pique our interest in understanding hypoglycemia as a diabetes-related problem, despite the fact that diabetes was always a high blood sugar problem. In the ACCORD trial, which was one of the landmark diabetes trials, they did actually show an increase in the annual percentage of individuals who experienced severe hypoglycemia by age. So those who were in the intensive group, as you can see, experienced significantly more severe hypoglycemia events if they were over the age of 75 or between the age of 70 to 74 than those who were in the standard glycemic control arm, but that you also see this increase as well by age, regardless of whether or not they were in the intensive glucose control arm or if they were in the standard glycemic control arm. But I think to an epidemiologic audience and clinical audience who is very well versed with population health, we know that there are also severe limitations with using trial data to ask epidemiologic or distribution type questions because they have generally low external validity, particularly as it pertains to older adult populations with diabetes. landmark trials have excluded people with past severe hypoglycemia events or impaired awareness of hypoglycemia. And remember earlier, I said that impaired awareness begets severe hypoglycemia in a vicious cycle. Generally, they're also, the mean age is between 60 to 66 years old, with a very small percentage of people included who are over the age of 65. And then there's also very little information known about the disaggregated samples that are defined by, for example, functional loss, frailty, or other types of cognitive issues. These were a couple studies that were conducted out of the UK. And what they wanted to look into was, to what extent are these landmark diabetes trials representative of a real world population? So they took what they figured to be real world populations, which for them were just large registries of patients, and they do quite well actually in the UK. And in Europe for coming up with these nationwide diabetes registries. And then they compared the sample or the eligibility criteria that were included in these large trials to see, okay, what percentage of the real world population would have been included? We see it's extremely low. So in the ACCORD trial, which is one of the most important and highly cited trials in diabetes, only, you guys can't see that. There's a bar thing here, sorry. It's 11.4% of people were included in that study that would have been considered representative of a real world population. It goes up to 35.7 in the advanced trial, but still only 1 in 3 is not very good when you think about using these types of trial data to form epidemiologic questions of incidence and distribution. To further demonstrate this, one review looked at what happens if we change the eligibility criteria or look at studies where the eligibility criteria focused only on those among whom severe hypoglycemia did not occur previously. We see that when you look at those reported rates, they're much lower than if you were to include individuals who did report having a past severe hypoglycemia event, and that trend persisted for incidence proportions as well as for incidence rates. So then around the turn of the century, access to large data sets, registries started to become more prevalent. And I think researchers dove into this, rightly so, to see if we can kind of get a better understanding of what's happening in the real world. And this was hypoglycemia and diabetes researchers, this was no exclusion, or no exception, I should say. Advantages of records and healthcare services data sources. So they generally provide you a large and heterogeneous population, relatively valid inputs. They tend to be feasible to access and to gain data from, and they're continuously updating. So we know that for the most part, they can be quite current and relevant. Some very compelling data that came from an analysis of hospitalizations related to adverse events. And what we see here is that adverse events resulting in hospitalization for insulin in this study were basically comparable to those resulting from warfarin. We don't really talk about insulin in the same way we talk about warfarin, though. We also see high rates attributed to oral hypoglycemia agents. And for oral hypoglycemia agents and insulin, both of these were about 19 to 48% higher than what is recommended by safety boards in the United States of what we should be willing to accept for adverse events related to drugs. And for both of these, it was 95% for both of these medications, insulin and oral hypoglycemia agents. The adverse event was hypoglycemia 95% of the time. We also know from hospital admissions that the rate of hospitalization for severe hypoglycemia increases with age. Those who are 65 experience more than those who are 55, and this trend goes up the older the individual is. Interestingly, also from this analysis, you can see from the dark to the light, there really isn't a decrease in those rates of hypoglycemia that are occurring within these age cohorts, suggesting we have a lot of work to do in trying to bring the rate of level 3 hypoglycemia down, or in this case, actually hospital-related hypoglycemia. One study from Europe, although this has to be looked at in the United States, suggests that among people with type 2 diabetes who are on a sulfonylurea agent that can induce hypoglycemia, who experience hospitalization related to hypoglycemia, may be living in a nursing home. So that's also another context that we really need to start looking into. So this is work that actually Rosalina was involved in, I believe, And it looks at what is the trajectory of hypoglycemia and hyperglycemic related hospitalizations. And this is the one study that went up to 2010. And I know there was a 2018 update of this. But what you can see is that hypoglycemic related emergencies resulting in hospitalization are actually higher than those related to hyperglycemia. And while this trend persists across age, you can see that those who are over the age of 85, we really don't see a decrease in that rate or an abating of that trend. But there are limitations with records. Depends on the coding of the condition as a separate diagnosis or a reason for that encounter. The diagnostic criteria are often not explicit or consistent. And then we can also think about the analysis of free text clinical notes, but in those analyses that have used natural language processing, it really hasn't demonstrated that much more improvement. And most importantly, it is limited to those hypoglycemia events that result in healthcare utilization. What do you think is the percentage of severe hypoglycemia that results in healthcare utilization? 10%. I got 10%. So we didn't really know. And there were some studies, hardly anything that was done in the United States. And so we thought, okay, let's use the informed data to see if we can understand where these events and how these events are treated. So here we only looked at individuals who were over the age of 60. And what we found was that only 5% of all severe hypoglycemia events resulted in some kind of hospital visit, be it ED with or without admission to the hospital. And in fact, that 5% also encompasses paramedically treated events that did not result in transportation to the hospital. So that means that 95% of events may be undetected by health service records. And so while they might be real world in the sense of including a lot of people or including a very heterogeneous population, from a characteristic perspective, when it comes to being representative of the outcome, they are not. So now let's talk about person self-report. Advantages here reflects the lived experience, relatively easy to obtain, you might argue with me on that, necessary for the total spectrum of level 3 hypoglycemia detection. This is going to be my premise. They can be generally derived in two ways when we think about hypoglycemia. So we can think about capturing it at point of care. So that's a clinician asking an individual, how many events did you have? And then we can think about a survey. Let's focus on the first one, point of care. So we know, as I mentioned, that the symptoms of hypoglycemia can differ by age. And in this study, they looked at adults versus the elderly. We see that, yes, there's an autonomic response, a neuroglycopenic response, but among the elderly, we start to see more neurologic responses, visual disturbances, incoordination, impaired balance. And this means that hypoglycemia in this population can be easily misdiagnosed, for example, as vertigo, visual disturbance, in one study, even stroke. And it can also be easily misinterpreted as related to dementia and as a response to symptoms like agitation or behavior change. In one study, they looked at, are hypoglycemia events even being reported to clinicians? I mean, if we think about point of care interactions, do we even wonder, I mean, how accurate are they? So in this study, they found that 65% of people with diabetes underreport their hypoglycemia to their clinicians. And maybe even more alarmingly, one of our studies in Canada showed that 85% of people with diabetes underreport their severe hypoglycemia events to their clinicians. Why, you might ask? There are a ton of reasons, primarily related to driving. And in this study, also related to whether or not the clinician asks about it. This study found that about a quarter of people with type 2 diabetes and 15% with type 1 diabetes were not asked about hypoglycemia during their routine appointments whatsoever. So if you're not going to ask, then obviously your patient is going to be less likely to tell you about it. And this underappreciation can worsen as the individual ages. So you have the obvious time restrictions and the limited documentation related to severe hypoglycemia, any standard clinical encounter, and then the emotional impacts that even a physician might experience around managing hypoglycemia. To what extent do they experience discomfort, indifference, overwhelm about having to deal with hypoglycemia on top of the myriad other problems related to diabetes, insufficient knowledge around how to manage it, disbelief, And then again, that misclassification, misattribution that starts to exacerbate in that elderly population. And then in people with diabetes, impaired awareness and the prevalence of impaired awareness also increases with advanced age. There's the risk for severe hypoglycemia-related amnesia and other types of cognitive impairment that can start to confound or influence and impede our ability to see and recognize hypoglycemia in practice. And all of this, again, is couched within feelings of apathy, embarrassment, discomfort, fear of the ramifications for reporting hypoglycemia, and then the symptom variability, as I mentioned. Not even knowing whether or not my hypoglycemia as I'm aging is hypoglycemia anymore because my symptoms have changed. And then,
What do you mean by impaired awareness? You mentioned that.
so I'll give you sort of my very basic schematic of it, but it's a clinical syndrome. So they can be generally, so as I mentioned, generally derived in two ways. So we talked about point of care, so let's talk about survey data. So in this study, they found that rather than relying on data where the clinician asks a person about their hypoglycemia, what if we gave them an anonymously completed questionnaire? And in this study, they reported that those hypoglycemia incidence rates were 2 to 3-fold higher. So when an anonymous questionnaire was used versus an anonymous reporting mechanism, the rates were 2 to 3-fold higher. So we use this. In Inform, we administered anonymously collected anonymous questionnaires to a panel of individuals over a long period of time. And this is what we found in individuals over the age of 60, that hypoglycemia, severe hypoglycemia specifically, and I'm going to define this by the level 3 guideline definition of any event resulting in healthcare utilization or not. So those events that are treated at home by family or friends, affected on average about 1 in 5 people in that past year. Perhaps not surprisingly, more people with type 1 experience at least one severe hypoglycemia event in the past year. And I've also broken it down for you here by whether or not it resulted in healthcare utilization. But really the point here is to demonstrate the fact that healthcare utilization represents just a small fraction of the total amount of level 3 hypoglycemia. The incident rate trends are generally the same, but to direct your attention to the fact that while in previous studies from RCTs and observational studies reliant on claims or health services records, rate of hypoglycemia might be less than 1 event per person year. Here for type 1s, it was actually 2 events per person year. And these may never be reported to a clinician or documented in a healthcare record. But there are, of course, limitations to self-report. Event elicitation during routine care, as I mentioned, is subject to bias. There are person factors that can affect detection, like impaired awareness, and I'll elaborate on that shortly. And then how do you ask about it? We don't know yet. We kind of have a sense of what the measurement of level 3 is, but we don't know how to ask that question. And while it might be good for severe events because of the saliency of those events, maybe not so good for non-severe hypoglycemia events that might not be as readily recalled by an individual and that might also occur more frequently. Enter the world of glucometers. So the advantage of glucometers really is that they can capture nocturnal and asymptomatic hypoglycemia. And compared to what we've been doing previously with people with diabetes, where we're trying to get them to finger prick multiple times a day, we now have continuous glucose monitoring devices that allow for continuous readings of glucose. I don't know if you guys have all seen them, but you can just put them on the back of your arm and your glucose data goes right to your phone. Continuous readings. Also now they're embedding really sophisticated algorithms for predictive trends. And there's an option for alerts. There's even remote sharing. So if you have a loved one who's interested in supporting you or has been supporting you, they can see what your glucose data are. Issues around panopticon needs to be looked at. There's wide data accessibility and generally a low burden of use as reported by trials and research studies investigating that. So in this study, they found that of individuals who reported having a hypoglycemia event, that those who were in the high A1C range versus the low A1C range had a lot of unrecognized hypoglycemia, asymptomatic hypoglycemia, otherwise just not documented, probably because they were using finger pricks and they actually weren't being captured in any type of glucose log. And this was also consistent across type 1 and type 2. Continuous glucose monitoring has also started to help us understand how does prolonged hypoglycemia impact health? So we now have a new metric, time below range. So rather than just looking at the event itself, we're saying, okay, how long is this person actually spending in this low glycemic range? It's supposed to be 1%, which equates to 15 minutes per day. And in this study, you can see that very few individuals are actually achieving that target. Here, this was actually presented last year at the ADA, and what they saw was that not only are people not reaching that target of less than 1% a day spent in time below range, but that those who are female are more likely to experience a longer time below range than males, and that cardiovascular disease concurrent to diabetes also increases that duration of time below range, and of course, history of severe hypoglycemia. And in this population, while they did not find statistical significance likely due to a lack of sample size, there was a salient effect of a difference between individuals who reported being of non-Hispanic white versus non-Hispanic Black origin in terms of the severe hypoglycemia rates that were reported. Prolonged hypoglycemia can reduce symptom response. So in this study in blue, this is short hypo. So they induced a hypoglycemia event in a participant for 5 minutes. And then they looked the next day at what was their symptom response. And this graph becomes really important when you look at the relative impact of the duration of hypoglycemia. So the longer the event, blue being the shortest, yellow being intermediate in length, about 30 minutes, prolonged hypoglycemia, 90 minutes, you see a decrease in that hypo response, which means that person's ability to actually enact on that incipient low goes down, and that risk for hypoglycemia occurrence goes up. And so here's the rough schematic of impaired awareness of hypoglycemia. So hypoglycemia can reduce counterregulation responses, and then that can lead to lots of warning symptoms. And because you don't have that warning symptom to say, hey, I need to, take my glucose tab, or I need to take a sip of juice, hypoglycemia occurs. And when hypoglycemia occurs, it only exacerbates the reduced counterregulatory process, and then that can lead to impaired awareness. And here we can see that those who have impaired awareness, which some studies have been able to validate a one-item questionnaire that can be readily implemented in practice, they experience longer duration in time below range. What are the limitations of glucometers? They can overestimate lows, compression lows. There are people who wake up and they're like, oh my God, I had a nocturnal hypoglycemia event, like frequently throughout the night. What happened? Oh, you rested on it. You're not supposed to lie on the device. Bit of a complication. So then we tell people with diabetes to put it on the back of their arm, but that's a practical issue. Doesn't capture severe hypoglycemia, because remember, level 3 hypoglycemia does not have an associated glucose threshold. So how do we know if a person's actually experiencing severe hypoglycemia from glucose records? It's super great for non-severe, level 1, level 2. How do we know from a glucose record alone that they experience severe hypo? We can't. And then there's also major issues to uptake of CGM, particularly in the United States. And all of these issues are only exacerbated among the older adult population, where there are special dexterity issues, visual impairments, hearing impairments, and clinician bias. They don't elaborate it on this presentation, but one study found that clinicians actually were less likely to give CGM to older adults because they thought they just wouldn't use it or they wouldn't benefit from it. So what does it all mean? Connecting the dots. This is not exclusive to older adult individuals, but I think it's a really fantastic review. So they just wanted to look at whether or not, if you had a super narrow cohort where you defined individuals hypoglycemia with the need for third-party assistance versus having a real-world cohort where you only required admission to hospital for ED care, just like health service records, for example, versus a real-world cohort where you have a very broad definition of hypoglycemia, like the level 3 definition. What happens to the rates and incidence reports of hypoglycemia? And they go up, not surprisingly.
What's the unit on the y-axis?
Oh, yes, you can't see that. That's the incidence rate. Year
What's that?
per person. Per person year. So the incidence rate is on the right. You can't see that on the y-axis. It's the annualized incidence rate per person year. And then on the right, it's the incidence proportion. But really, it's just to demonstrate the fact that these different sources of data that we've been relying on have been giving us wildly different understandings of what the burden of hypoglycemia is. And actually, to the extent that trials, where we might, kind of just assume might report the lowest, actually healthcare records that report the lowest overall rates of severe hypoglycemia. So I'm going to challenge the concept of real world and maybe move towards a more anti-faith world. And I think the distinction becomes important because is our goal really, I mean, are we really trying to get the absolute truth with every single time that we conduct a study? No, we're just sort of inching more towards what's real. So we're trying to reduce the bias that exists. So I created a spider web diagram for you, and I'm going to compare, just summarize some of the studies that I've talked about here. So trials, poor population coverage, the risk of bias is high because they're going to look at that very select population, exclude those who are sicker, include those who are healthier, include younger individuals. There's narrow eligibility criteria as a response, restricted risk profile, but in terms of low risk of bias, the documentation of events is very robust, tends to be very valid, adjudicated by clinicians, but just limited. Routine healthcare records give some advantages from the sample heterogeneity perspectives, takes advantages away from the outcome measurement perspective. Healthcare provider event elicitation. We know that it's real world because that's the interaction that's happening, but there's that major bias where an individual might not disclose and that clinician might not ask. Continuous glucose monitoring, really awesome, but limited for the most part, and importantly, on its ability or inability to detect severe hypoglycemia events or at least capture it definitively. Anonymized questionnaires really seem to have a lower risk of bias comparatively, but at the end of the day, nothing is perfect. And so the next steps for research, we need to think about these subpopulations that exist within the general population of people with diabetes, especially those who are in this older adult context, especially as the diabetes population continues to age with both type 1 and type 2. We need observational studies, randomized control trials, and qualitative studies. We need to think about how can we integrate qualitative studies into epidemiologic research, either through mixed methods design and even embracing some of the methods that qualitative researchers use as quantitative researchers to be more reflexive about how we actually approach research from a quantitative lens. And all of this has to be done with a network of researchers ranging from epidemiologists, healthcare economists, basic scientists, clinicians. People with diabetes themselves have to be included at the very formative stages, the idea generation stages of research. And then also thinking about industry partners and how they can play a role. These are the people making the drugs for the most part and putting the drugs out into the world. Can we work with them to help better their distribution and also that they can help us do our research better as well? Personally, inform knowledge exchange outreach. So anybody who's interested in working in Inform, love to collaborate. Hopefully, we're going to be able to conduct a pragmatic trial that actually looks at implementing the risk prediction model that we were able to develop from Inform into real-world practice settings to see can we actually reduce severe hypoglycemia among people with diabetes. Rosalina and I are actually working on a primary care compendium for the American Diabetes Association that specifically looks at hypoglycemia management. How are we going to do this? How are we going to capture it? What's the onus and accountability of a clinician to actually start recording it, documenting it, and talking about it with their patients who have diabetes? Various policy and position statements I've been involved on, working with Dexcom to try to get in Canada continuous glucose monitoring more readily accessible to people, regardless of whether or not they can pay for it. We're still seeing that across historically marginalized communities, there's lower uptake of CGM. Position statements as well with the International Hypoglycemia Study Group. Can we come up with a way to capture severe hypoglycemia that is valid, robust, can be used in trials, and can also be used in clinical practice and influence guidelines? Equity. Can we make CGM more equitable in terms of its access across the whole population? We can learn from other countries. NHS has done relatively well with these initiatives. How can we learn from international and even state collaborations or state lessons so that we can build those collaborations and actually do it right when we roll these types of devices out? Personally, I want to start looking at diabetes and menopause. Huge blind spot in the diabetes space. And we can start now using continuous glucose monitoring to start seeing how do individuals who are experiencing menopause experience not just the physiologic responses to hypoglycemia or to hyperglycemia, but also how does that impact self-management and more. This isn't my citation. This actually comes from an individual who has done a ton of geriatric research in the diabetes space more. There is just too little research that is done in the older adult diabetes population, especially those who are at risk for hypoglycemia. But even beyond that, we need to think about type 1 prevention in an aging population. We also need to have better economics data. Can we look at the broader context of diabetes to include significant others of people with diabetes and even healthcare providers? And what are the economic benefits that they can incur as the landscape of diabetes therapy and technology changes? More broadly on the horizon, let's think about some cross-functional connections nationally and globally. How can the United States partner with Canada? And how can it also partner with Europe? How can we partner with Asia and different countries in Asia around the world? How can we build the evidence base that we currently have in hypoglycemia and also build the social capital and the intellectual capital that we have within our own teams? We have to focus on community and person-centered research. I mean, this is a must, especially with the increasing globalization and access to technology. We have to start thinking about how we're going to engage participants better in research and better in the ultimate results of that research. Create longitudinal, real-world, researchable registries with real-time data linkage. So actually, Scotland has been able to do this. Their entire country of people with diabetes, they are in a database, all of their clinical data, their hospital data, their EHR data, they all go to the same database, and they've even been able to link their real-time wearable device data for those who are using glucometers into that database. On top of that, it's researchable. So anytime you want to administer a questionnaire to assess a prompt, you send out the questionnaire and it's a researchable panel. How amazing is that? We could do that. We can work with those people who are already developed that, who are working on that, to give lessons learned on how we can achieve that here. Expand research with equity denied populations. We know that there is too little information that is out there and decisions are being made about equity denied populations that shouldn't be because they are not represented in research. We need to focus on this. And all of this needs to work towards augmenting the global evidence base. How does the United States play a role in the global landscape? And then all of this eventually will be to impact clinical practice and policy in the United States and hopefully even beyond that. So thank you so much for your attention. And again, thank you so much for your patience. You can scan the QR code if you want to learn more about the Diabetes Alliance and the work that we've been doing at our team. You can add me on Twitter, my shameless sort of way to get some more followers. And I'd now like to invite any questions.